Hello, I'm Dr. Annalene Weston, dental legal consultant at Dental Protection. Welcome to RiskBites, a series of podcasts created specifically for dental practitioners in Australia. RiskBites looks at the key dental legal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. Today, I'm talking with my colleague and fellow dental legal consultant, Dr. Colm Harney, about the compassionate release of super and how this relates to dentistry. So, hi, Colm.
Hi, Annalene.
Now, Colm, this is certainly a hot topic currently for several reasons. And I think first and foremost, that drip feed of negative publicity around it in the media is regrettably being seen by many as a free hit to the reputation of our profession. Don't you agree?
I do. Yeah, we'll talk a little bit about all of that later on and why people might be getting upset about it and negative publicity and all of those sorts of things. And I think as well as that, the scrutiny and oversight that's bearing down on this scheme as well. But we'll park all that for now, and I just want to start right back at the basics with what this is all about. So compassionate release of superannuation, or CRS we'll call it for short, it's a long-standing provision that allows individuals to access part of their Australian superannuation savings early in cases of severe financial hardship or compassionate need. So it's designed as a safety valve within the otherwise very strict preservation rules that restrict access to their super until retirement age or meeting other conditions. And it might surprise many people that this scheme has actually been around since 1 July 1994, just shortly after the creation of the modern superannuation framework here in Australia. However, since 1 July 2018, the authority to approve CRS applications rests with the ATO. So remember that name, the Australian Taxation Office. It's an entity I think we're all familiar with, but we'll talk a little bit more about that later as well.
Yeah, that's great. It's interesting it's been around for so long because it's only really been, I guess, a source of interest in the media regarding dental treatment for such a short period of time, relatively, hasn't it?
Yes.
So compassionate release then, you mentioned severe financial hardship or compassionate need. And I think it's really important, Colm, that we're going to have to be we really need to explore what these terms mean for our listeners, because I think it's time, isn't it, that we really address this and start to separate fact from fiction and do a deep dive in what this scheme means and what the risks are.
Yeah.
So if you can start off with that would be fantastic.
Yeah. And I know in broad terms, dental practitioners like guidelines and rules, and we like our guardrails, and we like to know where we can go and what we can and can't do. So I'm going to reference this straight from the ATO website, and we will put links to all of these references in the show notes as well. But I also want to make a very loud and clear disclaimer here that this information is general in nature, and there are many, many considerations and varied and potential sources of information that may come into play here. And it's also current at time of release, because this is an evolving space as well that we need to consider. So,
yeah, but we do need to address, I absolutely agree. And it's really important that you put that. But we really felt that now is the time to look at this. So caveats done then.
Let's start with the fundamentals. Yeah. So the fundamentals are, there are 6 categories in which you may be able to access CRS to meet these expenses. The one that I think is relevant in this conversation is medical treatment for you or your dependent. And I'm going to quote from the ATO website, so the body that oversees the application. So if you apply for CRS for medical treatment, the law states that treatment must be necessary to, so one of 3 conditions: treat a life-threatening illness or injury, alleviate acute or chronic pain, or alleviate acute or chronic mental illness. And it goes on to say, to access super early for medical treatment expenses, you must provide 2 medical reports with your application. At least one of those reports must be from a specialist treating one of the above conditions. The reports must state that the treatment is necessary to treat or alleviate one of the conditions above, and that the treatment is not readily available in the public health system. And that's end quote. So under that legislation, medical treatment includes dental treatment. For dental treatments, certification is required by either two dentists or a medical practitioner and a dentist or dental specialist. And I don't know what you think here. At first glance, you think we generally don't treat life-threatening conditions in dentistry, nor are we capable of diagnosing or alleviating mental illness. So most dental applications will fall into the basket of alleviating acute or chronic pain.
Yeah, intuitively that feels right, but there's going to be some outliers too, aren't there?
Yeah, there are. And you knew I was setting that up there. So I'm not really a stats or a spreadsheet kind of person, but this area does interest me. And I've done a bit of a deep dive into the facts and figures. And these are all freely available again on the ATO website.
That's great.
So the last financial year, the 24-25 financial year data was released in October 25. So there were actually 675 cases approved for life-threatening illness or injury, 520 for acute chronic mental illness, but the vast majority, in no surprise, so about 31,000 or 96% of all successful applications fell into the alleviating acute or chronic pain category for dentistry.
That's fascinating. So straight away, you've hit us with a quite big number about how many cases went through the ATO last year. That's extraordinary.
That's a big number.
Yeah, it's a big number. Hey, so stepping through severe financial hardship or compassionate need. 6 categories.
Yep.
And the one that's relevant for us is medical treatment. Okay. The patient has to meet one of 3 specific criterion.
Yep.
And there has to be 2 reports to say so. So that sounds quite prescriptive. So what's the problem here? Why is this an issue?
Okay. Really good question. And I think where is this falling down? What's happening? Well, I think, again, first of all, it's important to state that this is a well-intentioned scheme. And I believe the vast majority of practitioners and treatments involved in this, it's treating patients with everyone's best interests in mind. And hopefully, we're going to talk about this in a compliant manner.
Yeah, I agree. And I think that's a fair statement to make. And while we know, like in every walk of life, there are outliers who behave poorly, we also know that their vast majority are well-meaning practitioners. There are some of those, however, may be poor administrators or unsure of the rules and just go ahead because someone like a patient or a principal has asked them to. And we've seen this in other schemes, of course, where the administration's been the falling down point here. And so this can be a big concern, can't it?
Yeah, I think so. And I think that there's going to be a bit of all of that. So that the poor compliance, the practitioners who may be pushing the boundaries a little bit, and also just admin issues and all sorts of things. But I'm going to take us back to that negative media publicity that you referenced at the start, and that scrutiny word that you mentioned right at the outset. I just want to set the scene for that and the players involved here in this scheme as well. So we referenced already the body involved in overseeing the scheme, the ATO, Australian Taxation Office, and the body getting dragged into this that regulates the practitioners, us, the dental practitioners, so that's AHPRA, are both getting sufficiently concerned about the CRS process to have released multiple statements now and practitioner resources in the last 12 months or so. So we're seeing an expression of concern that's ramping up in terms of seriousness and wording as well. So started off in December 24. Both national boards, which is dental medical boards, raised concerns about the high rate increase in CRS for dental and medical treatments in the previous financial years. So a few more, maybe shocking figures to some if they haven't heard these before. But nationally, the value of CRS release for dental treatments, so just dental treatments, not medical, increased by 68% in the 23-24 financial year to $526 million. So just let that sit for a second. Over $500 million spent in dentistry in the scheme in 23-24.
That's a huge number.
It's a huge number. So we're all waiting in sort of latter half of year 25 to find out what the 24-25 numbers were. And probably in no surprise, if you have a look at the graph, the dental numbers jumped again to over $800 million. So with dentistry being primarily responsible for the continued uptick in that graph in the overall value of CRS withdrawals. All other medical, so there's a lot of other medical things like the big things in medical are IVF, bariatric surgery, all those things are just flatlined. They're not increasing at all. Dental is that classic hockey stick up curve going upwards. So hence the concern. So in May 25, joint statement from AHPRA and again the dental medical boards highlighted this significant increase. AHPRA CEO, Justin Untersteiner, quote again, "We are deeply concerned by reports that some practitioners may be putting their own financial gain ahead of their patients' best interests. We're working with the ATO to identify any potential predatory practice. Practitioners are on notice that we will take action to protect the public." End quote.
Yeah, I watched all these releases and the evolution with interest because the language is becoming progressively stronger and more punchy. And words like predatory practice, that's a worry. That's a real shot across the bow there at what AHPRA's concern here is.
Yeah.
Look, we always see that tension between commerciality and professionalism. It's something that we at Dental Protection discuss quite broadly, but this almost feels like the next level on, doesn't it, when we're talking about predatory practice for financial gain?
It is. It's very strong language. And then they've actually backed this up again now in October 25. ATO, AHPRA made a joint media release again. So again, quote, "We have joined forces to stamp out business models and inappropriate practices that seek to use superannuation to pay for overly expensive or unnecessary medical treatments." So that would include dentistry. So in that statement, they released new guidance, and this includes a warning for practitioners that providing financial advice without a license could also result in severe penalties from Australian Securities and Investment Commission. So another body stepping into the fray here called ASIC, which some of us will know of already.
Do you know what this reminded me of? Do you remember that Al Capone went down for tax evasion? It sounds like a really silly thing to say.
No, it doesn't.
That's what this reminded me of.
Yes.
Does it you like this?
Oh, yeah.
Oh, and everyone's getting involved now. Hey,
everyone's getting involved. So if the risk of running foul of the ATO and AHPRA doesn't scare you enough, you definitely do not want to add ASIC to that list. So all the major criminal trials relating to financial irregularity and fraud that you see in the news and media in Australia, that's usually ASIC prosecuting those. And I really believe that this escalating language, and there's certainly veiled threat now, the words like predatory practice and ASIC and ATO are all stepping in, is directly proportional to the negative publicity that these agencies are now incurring themselves. As the public, the media, and many practitioners out there are asking what's being done to rein in whatever rogue practitioners might be out there, draining patient super funds and damaging the reputation of our profession. So everybody's copping heat now, and I feel that there's going to be a release valve, and that release valve is going to be dental practitioners, unfortunately.
Yeah, I don't disagree. And as we sit recording this, we're certainly seeing some different positioning in some of the wording of AHPRA investigations and what they're actually looking at. Language that we've not seen before, the areas they're investigating being different. And it's really because of this.
It is.
So you mentioned some new guidance, Colm. I think it would be helpful if you ran us through this, if you can.
Yeah, definitely. And again, I think they're becoming more prescriptive here because they know that's what we want. Well, we don't want general statements that AHPRA are watching predatory practice. We want now some guidance to tell us what what we can and can't do. And while there is some generality involved, I think it is relatively prescriptive as well. So if there's no other takeaway from this podcast, I would urge strongly anyone working in this space to read and understand this recent guidance from October 25. And again, it's all linked in the notes. And of course, if there are any questions, something our advisors would be more than happy to talk through and point people in the right direction and advise as well as we can. However, the key points here are, number one, putting patients' interests first and not being influenced by financial gain or incentives. And this seems like an obvious cornerstone of professionalism, ethical practice. However, there's no doubt that we are seeing areas of concern, such as, for example, promotional material on social media that certainly suggests blurring of these lines of professionalism, ethical practice. So, for example, encouraging patients on social media posts to access their super funds for cosmetic treatment, all that sort of thing. We're certainly seeing some of that out there. Practitioners must, in quotes, properly assess the patient. And again, thankfully, there's quite prescriptive guidance. So this is likely to include taking a history, performing an appropriate physical examination, and ordering any necessary investigations or reviewing the results of investigations ordered by other practitioners. So the expectation here is that the practitioner signing off on the forms must have physically seen the patient and done our old 101 that we learn in first year in dental school: history, examination, special tests, diagnosis, all the fundamentals of dentistry must be done by the practitioner. And why wouldn't it be any other way? We wouldn't expect anything else. So it says that it's unlikely that telehealth consultation is appropriate for the assessment required for dental and medical conditions considered by CRS. Now, obviously, there will be some exceptions to that, but that's what they're saying is going to be the broad standard or expectation.
It makes sense, because with that one, how would you assess someone's occlusion? I wonder. It's some really critical components, as you've said, of our examination. And of course, bearing in mind that this isn't just for dental, it's for medical too. And so I suppose you have to think about that quite broadly. So carry on.
Yes.
Thanks.
Yes. Yeah. And again, this is in the guidance and quite prescriptive. Any report must support the application honestly and accurately. And again, I don't think very many practitioners out there would disagree with that. And again, it's written into our code of conduct. When we write reports, certificates, give evidence, good practice includes that you're honest, not misleading when writing reports, certificates, and only sign documents believed to be accurate. So it's just linking in with our code of conduct and what's in there already. Yeah. So we're getting to the meaty stuff here now. Influencing patients to access the super early without an Australian financial services license could be considered financial advice and result in, this is the wording, severe penalties from the Australian Securities and Investment Commission, ASIC. So just repeat again, influencing patients to access the super early. And I reckon this is going to be tested, will result in severe penalties from ASIC. I don't think any practitioner wants to step into that territory. We know ARPA reasonably well. We certainly don't know what ATO and ASIC can do other than what we see in the media, and it's not good.
When I saw this one, the first thing I thought was, wow.
Yes.
That feels big.
Yes, it does. It does feel big. And it's something that it's a whole world of pain that we just don't understand, and I wouldn't like to see any practitioners getting on the wrong side of ASIC or ATO for that matter.
No, for sure.
Yeah. So doctors and dentists do not have a role in providing financial advice, but should encourage patients to seek independent financial advice. And I think, as a broad rule of thumb, any practitioner dipping the toe in this territory should have, as part of their consent process, I ain't touching you until you go off and seek independent financial advice about this. Would be my broad rule of thumb. That I can't see many exceptions as to why you wouldn't tell a practitioner or tell a patient to do that and document it.
Yeah, because that's one of the criticisms, isn't it? That if somebody draws money out their super now at 30, did they understand the long-term implications of that money not being sat in their super for the next 30 years? That's one of, when you see the rhetoric, that's one of the concerns that are raised. And also whether patients understand the next thing, which I know is a point raised in this guidance, which is the treatment for life?
Yes.
Or is it for a period of time? Because they address this too, don't they?
Yes. Well, you just referencing the next point really that I have here in terms of patients should understand the full costs of treatment. Now, I think you and I reading that sentence would understand that to be not just the dollar value of the treatment being provided there and then. This is at its essence referring to broad, informed financial consent. And I would suggest a good practice would include informing the patient of anticipated ongoing maintenance costs and the estimated life and need for replacement, for example, any implant-based procedures. So maybe giving the patients broad information based on the current data on the life of an implant. I think you would be well advised to do that as part of your informed financial consent process to cover yourself that you have consented the patient properly before going ahead and doing this treatment. Don't know what you think about that, Annalene.
No, I don't disagree with you. I think we probably have a broader overarching view of what financial consent means because of working in the cases and claims space and seeing how many patients don't understand. And it's fascinating really because nothing lasts forever. And people have an understanding when they buy a car that car is not going to be with them forever. Yet when they have, for example, a fixed implant retained prosthesis, the expectation on that patient's part about the lifespan, when we see the complaints, there's often a lot of confusion about ongoing associated costs and perhaps not necessarily understanding that if it costs $20,000 now, when it needs to be replaced in X number of years, what the inflationary cost of that will be. Now, it's a tricky one. But I think it's a really important part of the conversation.
It is. And unfortunately, we see it as a free hit for patient lawyers. If that's not clear in the consent process, patient lawyers often jump on that and see it as a free hit against the practitioner if they haven't consented the patient on those longer lasting costs that may need to be talked about. The last piece of the puzzle here is advertising. And this is a whole complex area, and we've talked recently about new advertising guidelines in the cosmetic space, but that really doesn't apply here because these shouldn't be cosmetic treatments per se or dominant purpose of being cosmetic treatments. So I refer people more back to the broad advertising guidelines, and there's a whole advertising hub on the Dental Board and APRA site. So I just refer people to that because it's very broad. But I would say that the guidance finishes with suggested examples of poor practice, and those examples include expensive treatments recommended when there are other satisfactory and cheaper treatments available without properly discussing the availability of those other treatments options and the pros and cons of different options. So we're talking about, again, a consent process where there's benefits, risks, alternatives, what happens if I do nothing, the fundamentals of consent that we talk about a lot.
And also cobalt chrome dentures. Yes, that's what we're actually talking about.
We are, in a nutshell.
The guidance, but that's actually what we're talking about, isn't it? You and I have talked about this in the past when we've just been chatting, but we're seeing implants being considered the only option for tooth replacement and no consideration being given really to some very, very tenable, removable options that are very satisfactory. Fixed options too, but like I say, removable options just not being considered in the first instance at all.
Yeah. And of course, if that's discussed and offered as an option and the patient declines that and that's recorded in the records, that's fine too, because we're balancing patient autonomy as well. But often we don't, unfortunately, see those discussions being recorded in the records. We probably know that a lot of times they are occurring, but they need to be documented and recorded in the records as part of your documenting consent. Another example is limited information being provided to the patient about ongoing costs. So there's that expectation now being put in writing that the board will expect that there is information being provided about ongoing costs. And I would suggest also about the lifetime of restorations, and also overinflating the cost of treatment when the funds are from the CRS. And that's something we are seeing a little bit of as well, or anecdotally certainly hearing about too.
Yeah, it's upsetting. That last one's an upsetting thought, that anybody would think that was acceptable. So it's interesting. I mean, obviously, I've just made the reference to chrome dentures as an example, but none of this guidance is about the actual treatment or the standard of care, or about failing work or adverse outcomes. We haven't even got to that bit. It's all just around using the scheme appropriately, and where this interfaces with these three big entities that have oversight: the ATO, ASICs, and ARPRA.
No. And look, that's a really key point here. So the varied possible interpretations of the legislation and the scheme rules before we've even done any dentistry. So the big thing in bold is compliance. Compliance poses a serious risk to any registered professional getting themselves involved in the scheme before they even pick up a handpiece or a mirror and have a look in a patient's mouth.
Yeah.
I'm going to just playing devil's advocate here, I'm going to lay out a scenario where a patient accesses CRS funds to alleviate, say, acute or chronic pain. So we'll take an example of
I think that's helpful, Colin. Super helpful. Yeah.
Yeah. So take an example of a patient presenting with acute pain due to irreversible pulpitis and this is diagnosed, and we've got an X-ray to show in a lower molar. So at the strictest interpretation, the scheme might be interpreted to only release funds to cover an extirpation. So to relieve that acute or chronic pain. So that maybe otherwise non-financial patient could end up out of pain temporarily, but worse off in a sense with a ticking time bomb of an incomplete treatment that they can't afford to continue. At the other end of the spectrum here, funds might be released for optimal end-to-end treatment. So the patient could access funds for extirpation, finish that molar RCT, have a core, full coverage, indirect restoration, and the job's done. How is this going to be interpreted if it was to be scrutinized as part of a review? And we actually don't know the answer to this. What about the rest of a patient's mouth with broken and missing posterior teeth? Can CRS funds be released to cover that if they're all asymptomatic? So if there's no acute or chronic pain with those? I'm concerned that in the strictest interpretation of the rules for this type of example, the CRS funds are not there to treat disease per se. It's treating the acute or chronic pain. And if the CRS money is used to treat something that the practitioner maybe, in air quotes, shouldn't be treating under the rules, what's stopping the ATO saying, you shouldn't have done that? Give me the money back. And in fact, I'm going to go on to argue that repaying the money might be the best case scenario for many practitioners who are found to be non-compliant. Worst case is that someone decides some aspect of your application was non-compliant or even fraudulent, and it could become a criminal matter where the ATO and ASIC investigate, and APRA maybe suspend your registration until the matter is resolved. Now, I'm painting a best case and a worst case scenario here, but we actually don't know. This has not been tested.
No, we don't. As far as we're aware, this is untested and uncharted territory. But with all this increased rhetoric, there's definitely a sense, isn't there, Colin, that we're going to find out very soon.
I think this is going to be tested very soon, and it's just a matter of time. But I just want to add one more thing as a final point, and something that we see and hear anecdotally is that CRS is being seen by many patients as free money, just stagnating in their super fund. They've paid into it, they're entitled to it, and just waiting for a chance to fund that replacement tooth or some cosmetic work on the front social six, with maybe a bit left over to take the family in Bali to holidays. And it's important that the well-intentioned practitioner does not get sucked into the patient enthusiasm or short-term thinking, and ensure that the patient is informed and directed to seek appropriate advice about accessing the scheme, because we know that there are short-term implications of use of CRS. So there's an immediate drain on the fund and a possible also immediate tax bill to be paid on that drain of super, because it's income. It's seen by the ATO as a lump sum income in that financial year. So patients will be immediately expected to pay tax on it.
Yeah, and we've seen complaints where that's come as a real shock to the patient.
We have. For example, like a 40K super fund release, and they're getting a 12 grand tax bill tacked on to the end of it as well. And it comes as a surprise to everybody. There's also the long-term that you referenced earlier, the long-term impact of that loss of compounding of those funds over the rest of the fund's life. So say a 30-year-old releasing 40K of their super, what would that 40K have looked like by the time of retirement when they're 65 or 70? And as none other than Einstein himself apparently said, compound interest is the eighth wonder of the world, and practitioners might be denying patients access to that compounding of the funds over their life if they're not properly informed. There's also the long-term costs and commitments, as we referenced earlier, of the maintenance of the work, especially complex and expensive work. So is there a cost time burden for maintenance, such as returning for hygiene visits to have the all-on-X implants maintained every 4 to 6 months? And is there an expected lifespan for the work, and does the patient understand this? I've also heard spoken in terms of broader societal impact on a cohort of the population who may have reduced ability to fund their retirement and may have actually increased reliance on the state to do that. And that's something I suppose we don't immediately consider, but that's going to be 15, 20 years down the pipe. It's going to be something that is going to be talked about, I think.
Just sounds like more tax to me. It's more tax for me. That's what it sounds like.
It's like more tax for everybody, yes. Yeah,
for sure.
And look, with this increasingly strong rhetoric and specificity of the guidance, I think there is less and less excuse now for practitioners to plead ignorance and say, I didn't know, I didn't understand. And what's also increasingly clear is this is not a harmless enterprise where patients are accessing their entitlements that they pay into, and everyone's just playing with free money. What's clear is that this is not your judgment to make, or it's not your advice to be giving patients. And it really bears repeating that if you are working in this space, review all these recent statements and links to ensure that you've got a very sound understanding of the scheme and the boundaries around it. So review the ATO rules and comply rigidly. And I would strongly suggest staying cautiously within those guardrails, at least until this has been tested a few times. Because you and I know, I think it's part of the human condition that regrettably we don't sit up and take notice until it's too late, until the proverbial house is burning down. Yeah. And I fear that there are going to be some practitioners burned by this in the early stages of this being tested. So, as I said earlier, what I think findings of non-compliance might look like is clawback of significant sums of money. 6 or 7 figures is going to be talked about, I think, in many of those cases. But that could possibly be a best case scenario. I really do worry for others where findings of non-compliance might be worse, big sums of money, but also oversight, legal consequences, criminal investigations from those big hitters like ATO and ASIC. So I would urge practitioners to be very, very careful and to try and stay clear of these big hitters.
Yeah, it's worrying, hey.
It is.
This is a topic that we've been wanting to explore.
And wrestling with, I think, to know what to say. Yeah.
Definitely, because ultimately, we're not the arbiters of clinical judgment. We're not the arbiters. And we know that the vast majority of dental practitioners are good people doing good treatment with the best interest of the patient in heart. And we also know that there are outliers. Unfortunately, one thing that my time as a dental legal consultant has taught me is that sometimes it's not actually the outliers who get caught's not the right word, but you know what I mean. They're not necessarily the test cases. I can think of many examples where there's been an unsuspecting and really quite innocent practitioner who's been drawn into something, sometimes even against their better judgment, and then they've ended up being the test case. And it sickens me to think that this could happen to some of our colleagues. It really does.
Yes. Yeah, no, I agree. And I think the test cases may be things like compliance as well, more so than unnecessarily unscrupulous behavior. And again, that's really unfortunate, because when we see those compliance things, we really all say, this could have happened to me almost, because they're so, I hesitate to use the words innocuous sometimes, but sometimes they are. But the consequences, based on this rhetoric, that this increasingly serious rhetoric, I think the consequences are going to be severe for the first run of people through this ringer, I think. Yeah.
No, I absolutely agree. And it brings CDDS audit to mind, which I know was a long time ago, back in 2010. But I have been a dental legal consultant for a long time, of course. And I remember colleagues who were caught up in that, not because they were being raucous or outrageous, or the word rorting used to be used all the time. They weren't rorting. They simply did a checkup and clean. But it was because they did a clean before they did the paperwork. That was what caught them. And when you say the word innocuous, I think that sprang immediately to mind, that that's not an intentional abuse. That's just doing dentistry, but not knowing your administrative requirements. So look, thank you so much, Colin. It's sobering, but I think this conversation needed to be had. And I know that there are lots of other discourse going on about this as well. Thank you for providing those links. They will go in the episode notes so that people can really read. And as you've said, please, please, please understand the guidance. And one thing that we've learned through our 2025 podcast series, where we did have a stronger focus on guidance, is how valuable colleagues have found the conversation about the guidance, and also all the resources being in one place. So thank you, Colin. And I truly hope for the people that are listening that this is helpful in some way, shape or form.
Yes, I hope so too. Yeah.
I will also say, as I always do, that if you like dental protection podcasts, although you may not have enjoyed this one perhaps, but if you like dental protection podcasts and you'd like to hear more, please do subscribe and leave a review.